Welcome, everyone. My name is Jacqueline Hawkins. I'm the acting director of the Curtis Center for Health Equity. I'm also an associate professor here at the School of Social Work at the University of Michigan. And so before we get started, I just want to do some continuing education and housekeeping for folks who are joining for CEUs. So in case you don't know, in order to receive CEs for today's webinar, you're going to need to stay for the duration of the time and respond to each poll question. So there'll be a series of poll questions that you need to respond to. Also, our continuing education office is going to be sending the evaluation to those who have met the requirements about a week after the session. So please be on the lookout for that and fill out the evaluation when you get it. And also, if you have any questions at all regarding continuing education, you can email their office at ssw.conted@umich.edu. And so we hope you'll enjoy the presentation today. With that being said, we are very excited and lucky to have Dr. Jodi Jacobson Frey here with us today. And I'll do a quick introduction before handing things over to Dr. Frey. So Dr. Frey is a full professor with tenure at University of Maryland School of Social Work. She serves as Associate Dean for Research, and she chairs the Social Work in the Workplace and Employee Assistance Subspecialization at University of Maryland. She's also the founder and faculty executive director of the recently launched Behavioral Health and Wellbeing Lab, or BH Well Lab. So for the past 10 years, she chaired the Financial Social Work Initiative, and her research focuses on adult and emerging adult behavioral health and well-being, with an emphasis on suicide prevention, mental health, substance use, and the workplace. She's published an impressive over 100 articles, books, and book chapters. And in addition, she's presented her work and her research in particular nationally and internationally at many conferences. Dr. Frey co-chairs the Workplace Suicide Prevention and Postvention. Ooh, that's a mouthful committee, and she is helping to lead the dissemination of the national guidelines for workplace suicide prevention. So that being said, we're very excited to have you here, Dr. Frey, and welcome.
Thank you, Dr. Hawkins. Thank you so much to everybody at the Curtis Center for Health Equity for inviting me to speak today. And thank you to also Dr. Watkins for her leadership at this center and this initiative. So I'm thrilled to be here and see so many of you online, not only from University of Michigan, but also the other U of M down south where I am at UMB at University of Maryland. I'm going to talk for about 45 minutes or so, and I'll cut myself off so that we have some time for questions. But I'm really excited to share with you the national guidelines for workplace suicide prevention that have been in the works for a long time and have been launched and are actively being used by workplaces and professional organizations. So I'm going to give you some introduction today and think about many of us on the call are social workers or in helping professions, and what that means in terms of how we can begin to move some of this more upstream. Just for some introduction, and thank you for the bio. So professionally, I got into the field of suicide prevention coming more from my training as a clinical social worker. I really didn't learn about how to do suicide assessment and response in my practice until being in the field. It wasn't something that was taught extensively throughout our schools, and still much remains in terms of opportunities to increase that education and training, not only for social workers, but for all professionals as well as community members to learn how to ask questions about suicide. So I got very interested early on how we can do a better job understanding suicide and helping people to find reasons for living. Personally, I always work in the area of spaces and places where social workers typically aren't working. As you heard from my bio, I do a lot of my work in the workplace, and I find that it's very important to be a bridge and think about public health efforts in problems such as suicide. How do we reach out to people? And as a personal um, affected person that, did not want to seek counseling for most of my life. I'm a clinician. I can help myself. I don't need to see anyone. It was very important for me to also learn that I myself needed some counseling and could benefit from that. So I think, these guidelines I'm going to share with you today, hopefully will give you some ideas about how you can take this back to the folks that you're working with in the community, but also the places where you're working as an individual and a professional. So just starting off today, a quote from the Higher Education Center: to be vocal, be visible, and be visionary. There's no shame in stepping forward, but great risk in holding back and hoping for the best. And that's what I encourage all of us to think about today when we are looking at the guidelines and what we could take away from today's presentation and start to implement to make meaning. So as Dr. Hawkins mentioned, I'm very honored to co-chair the National Workplace Prevention and Postvention Committee. We are a multidisciplinary, diverse group, including many with lived experience that have come together over 10 plus years to think about how to bring suicide prevention as a public health effort into the workplace. So the first question I'm going to ask is, before today, how many were you familiar with the Workplace Suicide Prevention National Guidelines? And don't forget, if you want continuing ed credits, you're going to want to do this anonymous poll. So please go ahead and respond yes, no, or somewhat. And Kate, I am not able to actually see the results, so I'm going to lean on you a little bit to let us know when it looks like most people have participated.
Perfect. I will end it now.
All right. And there we go. All right. So I have an awesome opportunity here to teach you about the guidelines. So let's dive in a little bit. So this is what I would love for you to take away with to understand the role of social work in prevention and intervention in the workplace, to think a little bit more upstream, perhaps, than how some of us on the call that might be trained as clinicians have been focused, and maybe to become an official pledge partner, or at least to take some action steps. So looking at the data for suicide, after 2 years of decline, the most recent data, this is from the American Foundation of Suicide Prevention, which is a wonderful resource, not only for research and data, but for survivors and those that are affected by suicide. I talk with people every week, parents and concerned friends and loved ones, what to say, how to help someone who's grieving. And I always recommend the AFSP website for wonderful resources that you can share with your clients, and you can use also for yourself to help you think about getting comfortable with the language about suicide prevention. But we can see here that unfortunately, after a short 2-year decline, for those of you that follow statistics, our rates for death by suicide in the US are back up to our 2018 levels. And if you dive into some of the statistics, you'll find actually that there's a lot of health disparities in terms of who's affected by suicide. When we saw some of the initial reductions during the coronavirus, overall, we saw some slight reductions, but we saw other populations, particularly young Black individuals and other individuals that identified multiracial, Hispanic, Latinx, and also American Native, we saw significant increases. So we really need to think about not just looking at one statistic, but pulling that apart a little bit when we think about prevention in terms of what's going to make sense within our community and what types of interventions might be culturally responsive to the greatest need. So I am going to ask you a question to think about your own personal impact by suicide. And have you been affected by suicide? And that can mean a lot of different things. Have you lost a loved one to suicide? Have you been impacted by a work-related suicide? Have you supported someone who's fighting suicidal thoughts? Have you thought about suicide personally? And have you attempted suicide before? And Kate, when that looks like about complete, I'll have you turn it off and we'll see about our own lived experience in the audience today. So this is actually very similar to what we see in the workplace when we use these questions. So I can't see all of you, but I'm probably talking to some folks that came to this session for many different reasons, and some of that being lived experience. So it's important for us to know that whenever we're talking about suicide, especially statistics, that behind those numbers is a person's life and people that are struggling every day. I was just at a 3-day conference for the Construction Working Minds meeting, where labor and non-labor construction industry leaders throughout the country came together to not compete, but to join together for suicide prevention in their industry, which has the highest risk of death. And unfortunately, during that 3 days together, 4 people had a loved one or a friend die by suicide. So it's so important to understand that the question isn't if this is going to happen, but when, and how can we help to be prepared? Now, when we think about who is experiencing lived experience and touched by suicide in the workplace, it's important that we also include folks like coworkers. And we think about suicide intensity not always being the death, but also including attempts and caregivers. So that's why we had 90% or more people on this call think about like how you've been touched by suicide. So that's very common that we see. Now let's move into the workplace a little bit. Emil Durkheim considered suicide to be a society-determined phenomena and included work in there. Now, work has a lot of very positive factors. When work is going well, people feel connected. They have meaningful social relationships. It gives purpose and meaning. Most people want to work. They want to be productive. It also gives us structure, as well as other, means to quality of life. But when work is not working well, what we find is that disintegration of work also leads to individual and community suffering. And when workers are seen as profit or barriers to profit, we take the humanity out of the workplace. And this we're finding with research, which many of us already know, that this increases suicide risk. So when I teach my students to be social workers in the workplace, I talk about framing our work as a safety priority versus like a counseling or benefit. Because when times are tight, businesses often get rid of nice things to do in the workplace that are benefits, which could include counseling, but they don't get rid of what makes up the fabric of an organization. So if we can be a priority and the mental health and the well-being of our workforce is really seen as an upstream priority, then we're able to impact not only mental health, but we're also able to impact things like absenteeism or presenteeism when you're at work, but you're not focused on work, or incidents and accidents. I've been hired and worked with employers that had to drive down into what was causing accidents and injuries, only to find that fatigue, depression, anxiety, all of these, psychosocial aspects and behavioral aspects of ourselves were impacting the workplace in a negative way. So we try to frame this as a safety and health priority for work. So a lot of times when we're in the workplace, and if we're a social worker in the workplace, we might be the only social worker in the workplace. So we come with a different value set and a different perspective. And what I always found being in the workplace is some of the things that I thought were just common sense were not necessarily common sense to those in leadership positions at work. And so this quote is old, but still very powerful, from the Wall Street Journal, that the workplace is the last crucible of sustained human contact for the many of now closer to 48,000 people who kill themselves each year in the US. A coworker's suicide has a deep, disturbing impact on workmates, and these tragedies pose challenges that no one covered in management school. So most managers and employers are not prepared at all for suicide intensity at work. And that, I think, is something that social workers can really have a major impact on. I'm not going to spend a lot of time on this data, but I've been doing this work for 20 years with colleagues. I chair the national committee with Dr. Sally Spencer Thomas, who you noticed in the copyright has created some of the slides that we use for the training on workplace suicide prevention. And we, often saw rates of suicide increasing in the work we did, but workplaces were very quick to say that's a personal problem, that's a medical issue, it's not a workplace issue. We shouldn't talk about that here at work. We shouldn't deal with that at work. And we certainly aren't going to take any responsibility for that as a workplace. So we often had doors closed, even though we saw numbers in certain industries, especially with rates of suicide increasing over time. And the CDC came out with data that really helped to push forward initiatives in the workplace that we're seeing today for mental health and suicide prevention, where they looked at, are there differences by occupations and industries? And you can see the top major occupational groups up here that had statistically significant higher rates than average suicide death rates throughout the US for both men and women. Construction extraction always remains one of the top industries and occupations. Industry, maintenance, repair, arts, design, entertainment, and sports, transportation, protective services. And I do a lot of work on men's mental health and suicide prevention. They tend to be one of the most challenging groups to engage in traditional mental health for lots of different reasons, stigma and other barriers. So we take a look in workplaces at the data, and we find that with working age adults, the majority of suicides happen in male-dominated workplaces, which lines up, if you were to go back a couple slides before, with our national data where we see men die by suicide much more often than women. A lot of times that has to do with the lethality of means they're using, and we can see over 50% of the suicides in this country are by firearm. So what that tells me is that prevention is of utmost importance when we're thinking about how to reach some of the high-risk men in these male-dominated industries. Because when they're using a gun, we don't necessarily have another chance to try to engage with them, to think about what they might do differently next time. So what you're going to see today in the guidelines I'm going to present is moving upstream. And I just think that's critically important for social work and anyone who is in the field of behavioral health and well-being. So we launched the guidelines, as I mentioned, in 2019 on World Mental Health Day, but it took a long time. And similar to other areas in the workplace, bullying, harassment, discrimination, violence prevention, the US is a little bit behind some of our partner countries throughout the world. So we looked at other standards from Canada and from Australia. And then once that data came out from the CDC, we really had support to show industry leaders that they were part of what needed to be a solution to a major public health crisis. So we launched workplacesuicideprevention.com, and this is a site available. Anyone can access it. This is where the guidelines live, but I just want to let you know that if you go online looking for them, they don't live as a PDF. They're a growing living document, so you'll be asked to fill out a very brief survey and then have access to a growing learning community where the guidelines live, as well as a lot of our different resources. So I would encourage anyone on the call today to take a look and think about how what we're going to review might fit into your organization. The guidelines are supported by a collaborative partnership through the American Foundation for Suicide Prevention and the United Suicide Survivors International. So we worked using research, focus groups, and interviews with lots of different workplace and professional organizational stakeholders at all different levels, different industries, and we made sure that we included the voice of lived experience, which we do in every aspect of the work of these guidelines. We came up with these 8 guiding principles, and we try to bake them into all of the practices and the interventions, whether it be upstream, midstream, or downstream. So we try to integrate, it's not good enough to just do awareness anymore. We have to move to action in the workplace. We try to keep things sustained. We're not interested in a check the box, and we've done that. We want to have kind of a slow drip over time to really integrate and blend into the workplace. We are interested in harm reduction and thinking about not only means reduction and lethal means reduction for those of you that are trained in that, but also toxic work environments. Like, what are the larger aspects of work that contribute to harm, and how can we support leaders to change that? We're very interested in culture change and thinking about becoming a workplace of health, becoming a culture of caring, becoming a place where it's okay to not be okay, and you're going to get support for the resources you need. We're very interested in collaboration and protecting the dignity of people, as well as promoting well-being, connection, and taking action. So let's see how they come to life in some of these. Some of you might know the stream analogy. We use it a lot when we talk about suicide prevention to help people understand that movement from downstream to upstream. So within our national guidelines, we have 9 practices. We'll take a look at just a few of them today, but they're organized by upstream, midstream, and downstream, as you can see here. So the stream analogy, for those that you maybe don't know, is we'll start, envision yourself next to a river, and you're having a picnic. It's a beautiful day. You're enjoying your lunch, and all of a sudden you hear, "Help, help, I need help." So you turn around and look at the river, and what do you see? Someone's drowning in the river. So our fight or flight response, responds immediately, and we run over to the river and we pull that person out, and we apply CPR, and they live. And we feel really good. We just helped save a life. And so we're, talking to the person, we've helped them, and then we hear, "Help, help, I need help." Turn around, someone else is in the river drowning. We run back. We do the same thing again. We save that person, we pull them out of the river. But every time we pull someone out of the river, more people are calling for help. And then it's overwhelming. It's too much for one person to pull all these people out of the river. So you look the other way and you see there's another family having a picnic, and you say, everybody come now. We need more help. All hands on deck. So everybody comes running, that heroic phase of disasters and responding. And now you've got everybody's pulling people out of the river, but it's not organized. And so you decide, maybe I should train people how to do CPR. But training to do CPR or anything in the midst of a crisis is not the ideal time. And you find that there's just more and more people in the river, and there's not enough people to save them. So instead of continuing to pull people out of the river, you start to walk upstream, and someone downstream says, "Where are you going? Wait a minute, we need everybody here." And you respond and say, "I'm going up to the top of the river. I need to find out why people are being pushed in to begin with." And that's our whole message and takeaway for this suicide prevention in the workplace, is we have to start working really to move upstream so we can prevent some of the crisis and the crisis response needed downstream. So these are the 9 practices. The beauty of them is, as social workers in the workplace or professional organizations or leaders, we can start anywhere. Ideally, we want to have that top leadership support to help us look at policies and strategies that will reduce toxic work environments, job strain. But we also need good communication and leadership. But just as important is training. And that's often where workplaces start, when they'll ask, should we do a particular type of training for our employees or our managers? And I say, yes, that's a great start. And what can we build from that? And then having our crisis intervention. So let me ask you a question for our poll. What level of prevention do you think has the greatest impact? I think I've given you the answer on this one, but. Great. Kate, what's our responses look like? All right, you all get an A+. Very good. So upstream has a very strong impact when we do it right. But really all 3 are very important. So we're gonna touch on just a little bit about this. This is emerging research. Research in the workplace is fairly limited. But what we're finding are that there are research studies, especially the late Alison Milner was really a leader in starting to look at data from the workplace that linked job design and toxic environmental factors at work to suicide ideation and death. And we're finding that actually they are very much linked, not just from anecdotal understanding, but looking at the data and hearing from survivors about that influence of work leading to suicidal ideation. And I believe Dr. Hawkins has maybe worked on this as well, with folks at Michigan, looking particularly for the impact of discrimination on suicide ideation with Black men. And we are finding this in the workplace as well. The racial discrimination, the bullying, other factors that lead to toxicity in a workplace are not only contributing to folks leaving and burnout, but are contributing to suicidal ideation. So what are the pieces of this that we can influence? And I think it's important to, when you're working to change culture of a workplace, that you're really baking this in throughout the entire fabric of the organization. I'm not saying this is me, but some people I know, when they're driving along the highway and they see a state trooper, they slow down. And then what do? They look in the rearview mirror, and once they're at a certain distance, we speed back up. And we see that all the time with suicide prevention, mental health, and well-being initiatives at work, where we might have a training day or we might have a presentation like this today, and we leave there and we're like, that's a great idea, I'm going to do that. And then the effect wears off very quickly. So it's very important to make sure this is built in everywhere. And it needs to really be responsive to the culture of your work organization. When I work with lots of different industries, what I do in construction doesn't necessarily work in law enforcement or healthcare. The messaging is very important of how to break through some of those barriers. A lot of times employers have fears. When I first started doing this work, an employer that I won't name, we invested a lot of time to do a very comprehensive workplace suicide prevention program. And it ultimately got blocked by someone who happened to be in the psychology field, but believed the myth that if we talk about suicide, more people are going to die by suicide, and then we'll be held liable as a company. And so that myth and that voice of leadership blocked the ability to do anything. And unfortunately, during that time period, we experienced 2 more deaths of employees. So getting out there and helping HR, human resources, employment lawyers, and other leaders understand the myths and facts about suicide is very important. This is a resource that we developed through our committee that's freely available on the workplacesuicideprevention.com website. And we're finding it's really helpful because it gives tangible action steps on what to do about myths about suicide prevention. I put this quote up here because it just kind of makes me laugh. I was interviewed for about 2+ hours by Bloomberg News. And my quote was at the very end of the story about workplace mental health and well-being. And so I guess of all the quotes, I kind of like this one that they picked. They said, I said, no amount of yoga or mindfulness training is going to help make a toxic work environment better. And that is really where the shift is, I think, for social workers to think about, even as clinicians, which I was trained and maintain my clinical license. We have to start using our influence in the workplace to advocate for more upstream approaches that reduce the situations and the circumstances at work that lead to suicide ideation and contribute to it. So be bold, again, helping leaders to be able to share their story, to share their lived experience, to share that they've used counseling and they encourage other people to use it, providing the opportunity to use services in the workplace, paid time, using it during work time, making sure it's confidential. All these pieces are critically important. Suicide, I'm not going to go through this slide, but suicidepreventionmessaging.org, there's lots of sites on how to talk about suicide. You'll notice I'm not using words like commit suicide or successful suicide. These are terminologies that increase stigma. And so we want to be very factual when we talk about suicide, and we want to make sure that we are talking in a way that encourages people to open up. So if you haven't had a class recently on suicide prevention, please look at some of the resources there. I'm going to talk a couple minutes about some midstream approaches. I'm actually going to skip this model for time, but you'll have it in your slides. So midstream, we get involved in screening, and I think universal screening can be really effective in the workplace. I've done a couple studies now with male-dominated workplaces, with healthcare, and when you're able to do some anonymous screening, people do want to have tools to help themselves. It also can give the workplace, even from an anonymous pulse point, some data to understand how people are doing, how they're coping. And it's a great way to think about connecting folks with resources. A lot of times in the workplace, we have resources that are only accessed after you decide to call for help. The same thing when we think about like 988 and suicide crisis, mental health resources, we wait for someone to reach out. And the idea behind suicide prevention is, can we reach in? Can we reach out to the person so they can get help without having to wait? So one way that we can do that in a workplace is through different types of universal screening. Some people, when they're doing really well, they like to hear about that and how to continue to be resilient. And other people that may be struggling find that there's actually resources that can be helpful for them, and then how to access them. So these are a couple programs that I work with. The Interactive Screening Program, or ISP, is offered through the American Foundation for Suicide Prevention. I have a couple papers we're working to publish now. We did the first research of 21 workplaces that are using this anonymous platform. That's kind of the novel piece of it, is we do a standardized screening that includes suicide risk, among other things like depression, PTSD, and substance use. And then the person has an opportunity to dialogue with a counselor anonymously. The counselor doesn't know who they are. They can't track them down. And the employee holds that sense of autonomy and power of whether or not they want to share their information to seek further help or to continue talking anonymously, which is really unique and also challenging, for workplaces and for clinicians even to think about, like, how would I do this in an anonymous way? But we're finding some really fabulous results for help seeking that in my data that's not up here yet, from healthcare and from law enforcement workplaces that we looked at, individual employees that are scoring at the higher tiers for risk are more likely to engage in the anonymous dialogue, and then to be open to asking for a referral and their willingness to seek help. So we're very encouraged that this model offers something different than waiting for someone to call or being referred, but has another way to communicate and get some information to people that may be struggling. But not every program works the same in all the settings. And that's, one of the things in healthcare and the law enforcement samples that we're looking at, we train the counselors to use motivational interviewing techniques in their dialogue. So we want to encourage them to show empathy and ask questions and maybe use constructive confrontation, not to use jargon and diagnostic language. There's one more, not to list all the problems. I see you have this, and this. We want to keep it simple and communicative. But in healthcare, we found that asking questions in that dialogue really encourages people to seek help. But in law enforcement, which relies much more on peer models that we'll talk about, they use constructive confrontation and social norming. And that is significantly improving how someone seeks help. Whereas in healthcare, it actually detracted from help seeking. So we have these programs and these techniques, but I always encourage employers to not check the box and just use a cookie cutter approach. Think about what their workplace really needs, what's going to resonate with that communication, and what's going to foster the connection so that people feel comfortable getting help. I can't do a presentation for Michigan without mentioning the Man Therapy Michigan campaign. So I've been working in Michigan for 10 years now, evaluating man therapy. If you haven't checked it out yet, please do at mantherapy.org. I've done research on this to look at how do we engage men in the community to think about having some tools to help themselves and infusing humor So another presentation would be on man therapy, but a lot of workplaces are using this as a way to think about how to open that conversation about mental health and well-being with men who are at highest risk, who don't respond when we talk about counseling, mental illness, and, all kind of, withdrawal and isolation and sadness. They might be experiencing depression very differently, anger and irritability or impulsive behavior in conjunction with depression, that we normally think about that. So it's important to think about some different tools and techniques that are out there for your population. And this is one that we've been using in Michigan for about 10 years now. Let me see how we're doing on time. All right. I want to move into peer support because I think this is really where the future of mental health in the workplace is. When I had the opportunity to do employee assistance at NASA, one of my first jobs after graduation, I was at headquarters in Goddard Space Flight Center. We worked a lot with employee resource groups, or ERGs. And many of them took on additional responsibilities through peer training to be able to have a little bit more advanced skills than the general population, but not as much as a clinician, to talk with people about their mental health and their well-being, because people feel more comfortable when they talk to people that look like them and have gone through experiences like they have. It's not as scary to call a mental health counselor. We often talk about, like, just pick up the phone and call. But to someone who is experiencing, the worst day of their life, potentially, that phone might weigh 500 pounds, and it's not easy, and it might be impossible to pick up the phone and call. So when we think about the complexity of stigma or discrimination against mental health and put all of that onus on the person who's suffering to take that first steps, we really lose an opportunity to reach out and help someone and support them. So I think peer support, and there's many different models that can be very informal, like an employee resource group, to a more formal group, like I'm working with law enforcement in that study I mentioned, that has peers trained to do motivational interviewing and screening and referral to treatment, like an expert model. They're trusted first, and they can be that liaison to connect with someone and help them reach out to crisis resources. They're preferred in a lot of different communities, especially some of the male-dominated workplaces that I showed you from the CDC that are at highest risk. And they also help reduce the burden on the mental health system. So as we move into our downstream approaches, our crisis response is critically important, but we all know that trying to get an appointment with a counselor is taking longer and longer. And many people cannot afford to do that. They can't afford to take off of work. The hours might be after work. They have childcare and transportation issues. So there's a lot of barriers to just relying on our crisis intervention services for suicide prevention. So the more that we can help move this upstream, if you're seeing that, peer support is a really important aspect of a comprehensive suicide program.
That's it.
So I'm gonna close out with a couple downstream approaches and then have some opportunity for some questions. So this is where I spent most of my clinical career, is providing employee assistance services and outpatient behavioral health and well-being services to working age adults. And, again, I think about what are the programs that employers are buying. So that's often where I get called. And they'll say, Jodi, nobody's using our EAP, our employee assistance program. Utilization is really low. We don't think it's any good. Which one should we use? But I think it's important to kind of take a look. So at the upstream approach, we talk about doing an audit. What are the programs? What are your policies? Maybe you do have an EAP or another mental health program and no one's using it, because if you use it, word gets back. It's not confidential, maybe. Or maybe they're not, able to respond to the workplace needs. I've had, firefighters and police tell me, we went to that program and it doesn't work for us. It's not a good fit. It's not any good. They don't understand, what we go through every day. And I had to spend most of my session counseling the counselor because they were traumatized by what I talked about that I see at work every day of my life. So we have to make sure that the mental health providers that we bring into our workplace, number one, that they're comfortable and trained in suicide prevention. Don't be afraid to ask that of your providers. But are they also comfortable and trained in working with your population? And is it a good fit? And I think we have to invest in that also as leaders. So if you're a social worker in a workplace and you have an opportunity to talk with leaders, I always talk with them about the partnership between their mental health care and the workplace, that it's a dance. And we can't dance with just one of the partners in this, because we need to be promoted and supported as a program if anybody is going to feel comfortable reaching out and using the program. Most people, again, do not think about the workplace as being a resource for them if they're struggling with mental health or substance use or other personal or behavioral health related problems. But in fact, the workplace is where we spend the majority of our time, and it's a completely untapped and ripe environment to do all of this work: prevention, education, intervention, support for return to work, and resilience and recovery. I used to do secret shopper calls for mental health programs when I was working to evaluate them for companies. So I always encourage my students, call that number on the back of your insurance card. How easy is it for you to get an appointment or to talk to a person? So if you're in the workplace, you've got an employee assistance or other related program or wellness program, call them up. What's it like? Because if we're going to move this upstream, we want our leaders to understand what it's like to use the programs and talk about it. So we have to try them out ourselves. The other pieces in our 9 practices, there's 2 more that we talk about at that downstream level. The means restriction is important to think about, especially for different industries. So I've mentioned healthcare and law enforcement a lot because I'm in the midst of writing up some papers on that. But there's a wonderful training available that I would recommend to everyone. It's a SAMHSA evidence-based training called CALM, Counseling and Assessment for Lethal Means. I think I have some resources at the last slide. I personally did not grow up in a home that had guns and firearms, so I was not comfortable talking about them. I had a lot to learn if I was going to actually do suicide assessment and safety planning work when my client had access to a gun. And what would it mean for safe storage and safe handling and working with someone to remove a firearm from one's home? How do you ask about that? So it's a really great training, I think, for helping a lot of us on the phone that might be social workers that may not be comfortable talking about gun and gun safety. But it also talks about lethal means in terms of access to medication. And so, thinking about the hospital, working in healthcare and the access to means, what does it mean to do safety planning at work? And as a leader, how do we look at the systems to reduce access to care, not to reduce access to care, to reduce access to means, especially if we're in one of a high-risk industry. So these are important ways to reduce fatalities. The idea is that temporary removal or storage while someone's experienced suicidal intensity and crisis, to be able to help them get connected to supports that will give them what they need to look at their reasons for living. But even with all the prevention and intervention that we do, we cannot prevent, unfortunately, every suicide. And certainly when we think about suicide crises of attempts, or someone who's experiencing suicidal ideation, maybe acutely or over the course of their life, many people live with suicidal ideation day in and day out. We want to make sure that we've got a plan to help them and to help our workplace. So this overview, this guide is on the website. And it's something we created probably like 10 years ago. But again, it's very easy to use for workplace leaders that weren't trained in this area, that need to respond, need to be able to do something. So we try, as social workers and public health professionals and healthcare providers to make everything shovel ready for workplaces. So the easier it is for them to use, the more likely they're going to use our tools. So we actually have flow charts on how to contain crisis. We give them sample letters that they can edit to maintain that dignity of the person and protect privacy. We help them think about safe messaging guidelines and, what to offer. I remember as a counselor, if there had been a suicide or suicide attempt, I'd get called in right away to come sit in a room in case people wanted to talk to me. No one ever came into that room right away. People wanted to go home. They wanted to feel safe with their families after any kind of crisis. It wasn't until, after the immediate acute phase that people wanted to talk. So we have a role to help people understand what is needed short term or long term. And this guide really helps to think about, like, when is it appropriate to bring in mental health professionals to provide comfort for grieving, and then also to help leaders be able to communicate, look for trends over time, and how to do even long-term reconstruction with honoring anniversaries and milestones without dramatizing or glamorizing a death, and how to sustain. Biggest piece of this for me is how to bring it back up to prevention. I was, before we go there, I was given a nickname once at a workplace. I was given an award and given a nickname. The nickname was the Broom. I was doing employee assistance, and they said, anytime there's something bad that happens at work, Jodi comes and you sweep it up and we move on. And so that was a really uncomfortable, it was supposed to be a compliment. I didn't really take it as one because, anytime after a crisis happens, we want to recover. We want to help the workplace get back to that continuity of operations, but we want to also reflect on what can we do differently to prevent for the future and to improve. So I really see this as a loop where you might be called in as a social worker in that crisis response, the downstream approach. But as you form the relationships and provide that education to leaders, you can have a really important, impactful role of moving this upstream. All right, so this is our fourth question. So we've got one more after this and then we'll break. What types of midstream or downstream approaches are currently being done at your workplace or organization? And you can pick one that is currently being done. Maybe you have more, which is great. There's a more than one above option if you want. Okay, whenever you're ready, we'll see what people are doing, if anything. All right, so a quarter of the folks doing more than above, another quarter not doing any yet. That crisis intervention is definitely the most common, and then trying to move that to midstream with some of the screening and training. So very promising. Thank you all for responding to that poll. So if you'd like to change and do more than the above, you can take the pledge today. So we encourage everyone to take the pledge to make suicide prevention a health and safety priority at our website. It's something you can do as an individual, you can do on behalf of your organization. It doesn't mean that you're signing up for a commitment to do like a particular amount of time or resources, but it opens up access to have all the resources in the learning community. And we have had about almost 1,700 organizations and workplaces take the pledge to date. And many of them are starting with that crisis intervention, whether they're promoting 988 or they're doing some training, but they're really trying to start building the upstream approaches. And when you do that, you get a badge, because who doesn't like to be rewarded for doing really good, creative, good stuff? So you can work through the badge system online. So let me give you the last question. Now that you've learned about the guidelines, how likely are you to go online to take the pledge for your workplace or organization, or to go online to learn more? All right, what do we have for our results? Excellent. I feel like we've made an impact today, that over 50% of you are likely or very likely to at least go online to learn more, which is fabulous. These are some resources. I think the slides will be shared. So these are all linked to different places you can get education, some screening, some of the resources that we talked about. This is my information. I do quite a bit on social media to make it very easy for you to share information with your workplace. So there's lots of different opportunities to connect with me virtually. And I think we have some time for questions. So thank you so much for joining today and would be happy to answer some questions.
Thank you so much for the amazing presentation, Dr. Frey. As Dr. Frey just mentioned, we're going to open it up for questions. If you would like to just enter your question in the Q&A chat, we can get to them. I don't see any questions right now, which means I'm going to take the opportunity to ask a question of my own, which I hope will be helpful, but please do feel free to ask questions in the chat. So my question is, can you talk a bit more about your journey as a clinician and what prompted you to get into this work, specifically into the research side?
Yeah, so I was trained as a clinician, and I started working in the field in the area of mental illness and substance use in the community. And for the program that I was in initially, you had to literally try many different programs, and they did not help you in order to get into the program where I was, which was wraparound services. So by the time folks had gotten to my program for help, they had lost most of the connections to resources, jobs, people in their lives, stability, housing. But when I would do these biopsychosocial assessments that we had to do up front, everybody had careers, dreams, goals, connections, and mental illness and substance use took that away. And I always started to think, what if we could intervene earlier? I was never a believer that you had to hit bottom for your life to change. And so that's actually what brought me into workplace social work more general, was thinking about how to introduce the idea of supports and recovery earlier. So I got into employee assistance. But then I, was able to work individually and sometimes do management training and consultation, but I wanted to see like what interventions work or don't work on a broader sense, which brought me to research. And for suicide prevention, again, not being trained in my master's program and seeing none of my colleagues trained and being very fearful of this as social workers, but seeing that social workers provide the majority of behavioral health services in our country, I knew that from a research sense and teaching that, translating that into practice, we had to do a lot more. And the upstream approaches have really been, as I learn about workplaces, organizations, and systems, we, move, I think, naturally as social workers to a more macro outlook and perspective. And that idea of, how do we prevent this from happening in the first place? And that is the root cause, which is getting at the culture of the workplace, and which is the hardest to change and the hardest to measure for research. But I think the most powerful impact that we can have as social workers is to influence that change. And when you're a social worker in the workplace, you often have an interesting voice and pathway to be able to influence leaders and kind of infiltrate almost those systems that are oppressive and, would really benefit from seeing how changing culture not only impacts individuals, but it also helps their bottom line. And we have to learn to speak that language of business as social workers to do this work.
Thank you so much. Actually, that's a great segue into what'll I think will be our, we have 2 questions left.
Okay.
So that's a great segue. An anonymous attendee asked, can you talk more about the role of postvention in the workplace?
Sure. So Postvention, I used to, for like about 10 years, actually led an international committee on crisis response in the workplace. So a lot of it is based on our crisis response. And it in terms of a clinical approach, you might be doing things like psychological first aid or providing resources to an employee assistance program or a peer program that you connect folks within the community. But the other piece is helping the organization and the workplace to function. Because remember that one of those first slides was work provides an important structure, and it's very helpful in terms of recovery. So being able to work with leaders in terms of how do I communicate if there's been a death or there's been an attempt, someone's out of work for a period of time, I need to talk with my team about this, or someone's coming back to work. What are we able to share? What do they need? While also recognizing that people often have reactions and responses because they're coming to work with their own background and their own experiences. And so something that might be, okay, we're ready to move on. Someone else might be really traumatized and struggling themselves. So I think in any kind of crisis, suicide and other, we have to make sure that we're empathic and sensitive to the needs of our employees, and they may be in a lot of different places. So reminding leaders how to lead and how to be able to be supportive while also providing that structure that people can feel like I'm coming back, I'm contributing, and I am able to, build that into my own resilience.
Thank you so much. And so we have one last question from Keyshawn McMiller, and it's, how might some of these practices translate to the remote work industry? Are there any focused initiatives that you're currently engaged in that center around that growing shift?
That's a great question. It's coming up quite a bit in terms of hybrid and remote work. One of the leading risk factors for suicide within and outside of the workplace is loneliness and that lack of connection. And I think that's going to be a huge challenge for the workplace, is to think about how do we help leaders lead and feel like they're connected when we're working remotely for a lot of folks. Also for the workplace that can't work remote, what does it mean in terms of, different opportunities for flexibility and telework, and bringing those folks together in a unified workforce is very unknown right now. And so the practices that we're focusing on are to think about how your workplace is functioning and what makes sense. And so being able to provide leadership messages, communications, building that in, it can be remote or other. Being able to think about your trainings remote that are still engaging. We've got some places that instead of doing, 1 and 1.5 hour safety trainings where they've built in mental health messages, they're doing, 90-second, updates and messaging throughout the day and the week, just as different ways to get that messaging and communication in on an ongoing basis that's more palatable in a remote and hybrid type of setting. So we do have to try to think differently and innovatively. And I would say research is only just beginning in terms of what actually works and can be translated to those different modalities of working.
Thank you so much, Dr. Frey. We will be reconvening in 30 minutes for the shorter talk, but thank you.
Thank you so much. And if anyone has questions, feel free to reach out to me offline. I'd be happy to talk about your own unique interests in this area. And I'm very appreciative for all of you to spend time to learn about this topic. Thank you.